We're going to cut out a fair amount of these last two talks. We're going to go straight to cases. So we'll get close to being done on time, despite supposed to being done in 2 or 3 minutes. And just remember, as Kevin mentioned, get your post-test evaluations in, please. So give us your feedback, especially written comments will be helpful in planning for the upcoming years. And otherwise, I want to thank everybody for their work in the conference. Kevin, Brandon, Mike, thanks everybody for your help here in getting this ready. It was definitely a team effort. So this talk is about essentially high tibial osteotomies, but there's a multitude of other things that play a role in that. So we're going to basically skip almost to the end here. So again, this is articular cartilage damage here. This is medial femoral condyle. So that's raw bone there. That doesn't feel good in most people's knees. So this is kind of what we're looking at here. So the other thing is just a brief, so you're familiar with abrasion chondroplasty, microfracture. So those they're still occasionally used, but we know that debridement tends to do as well and many times better than both of these. So you'll see fewer and fewer abrasion chondroplasty or abrasion arthroplasty and microfracture procedures. Mirror stimulation has been found to be questionably effective at best here. So there are many other articular cartilage treatment options. So we used to do ACI. That was off-label use of the patellofemoral joint. Now we do MACI. It's essentially piggybacking on the same procedure. It is now approved by the FDA for the patellofemoral joint in addition to the other 2 compartments of the knee. So if there's underlying good bone stock, then that's oftentimes our treatment of choice as long as we can get insurance approval. The other thing that is very effective, we have excellent long-term results, is a fresh osteochondral graft. So fresh graft means never frozen, never processed. It's going to fit within certain dimensions of the recipient site. So somebody passes away, they happen to have pristine articular cartilage in the part of body that we need, and then that's what we transplant into that patient. So those have excellent 20, 30-year long-term results, typically around the range of 70 to 85% good excellent results, 20 years. So we're going to move past that. Other than just, you can see here's a knee that is not going to get resurfaced by MACI or fresh OC graft because we got tri-compartmental changes here. So this is reaming for a total knee right here. It's for an intramedullary device. So just something to keep in mind, both the health of the patient, their activity level, and also in particular their alignment. So the menisci play a big role in this also. So depending upon meniscus deficiency, that can alter some of these choices. So all these slides are in your handout. So here's the big one, alignment. So we talk about with the knee, and the similar concept exists for the ankle and the hip to a lesser extent, but the biggest thing we're looking at is alignment, stability, and articular cartilage. If we treat the articular cartilage without treating the alignment or stability, we will have an absolute failure very quickly. So that's part of the complexity of treating articular cartilage. We have to be able to treat all of the other things in addition to that, otherwise our articular cartilage repair or restoration will fail. So those concepts are vitally important. Any nicotine product, all these discussions go away. No insurance company will approve it. We will not do the procedure because the failure rates are astronomically high. So any nicotine users, forget it. BMI becomes a factor also, but the big 3 are going to be, again, alignment, stability, and articular cartilage. And then the other part, inflammatory arthropathy. Somebody has rheumatoid arthritis. Any inflammatory arthropathy, typically they're not going to be a candidate for any articular cartilage restoration. Doesn't mean we cannot get them good alignment and or stability, but articular cartilage restoration typically will be off the table. So somebody ACL tear. So here's our issue. Weight-bearing line through the inside of the knee, barely even within the medial compartment itself. So we can reconstruct that ACL, no problem. They'll do well short-term, but that degree of varus alignment is going to produce additional stress on the ACL. They're going to have a high likelihood of failing that ACL. So if we don't address the alignment, the likelihood is our ligament reconstruction will fail. The other part is the medial compartment will fail at some point also. So what do? We address the alignment. We address any interarticular problems, meniscus, articular cartilage, and we reconstruct the ACL. Same day, same time. So how about when we got the opposite of that? So we got valgus alignment, so somebody's knock-kneed. So we get that occasionally. Well, similar concept, but we cannot correct that in the same manner, or we'll have major problems with the position of the joint. So that this is a college basketball player. So valgus aligned, you can see his articular cartilage. We got some troubles there. So he had I'll show you here, distal femoral osteotomy and a fresh OC graft to his lateral femoral condyle. So we corrected his alignment and replaced his articular cartilage with fresh OC graft, lateral femoral condyle. So he's done well here in the first 3 years. So you can see changing the alignment of the femur is a big deal. That's not a simple everyday procedure. The long-term results are good, but it's got to be done with the right indications and the right patient. So as far as varus alignment, bow-leggedness, again, full thickness articular cartilage lesion here, 30-year-old. This happened on a boating injury. So they were persistently symptomatic. Here is his articular cartilage lesion, time of surgery. So he was also varus aligned, so we changed his alignment and addressed his articular cartilage. He did not have any stability or ligament problems. So this is a 4.5 square centimeter lesion, which by articular cartilage lesion certainly is getting on the larger side of things. So that is the ACI membrane right there, and high tibial osteotomy. So here's more ACI, HTO. So we've got lots of these cases, and we're going to move past most of those. But so the hip, this is just again regarding articular cartilage. This is myself, we're teaching at the Orthopedic Learning Center in Chicago. This is one of our cadaver labs, but so similar concept in the hip. Alignment is a big issue for the articular cartilage in the hip also. It's just that the alignment happens to be in a different manner there. Shoulder, articular cartilage, still important. Here's a single dislocation, full thickness articular cartilage lesion in a high school athlete. So again, alignment, stability, articular cartilage. Any questions?